and welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories but keep it edgy yet light-hearted.
Pod guests share their career-defining drug, song and book, and also share their joyful patient stories.
Welcome to the Oral Apothecary Podcast. It's Series 8. My name is Jamie Hayes. For this episode, we're joined by Dr. Jessica Morley. Jessica is an Associate Research Scientist at Yale University's Digital Ethics Centre. Her work focuses on reimagining how digital health technologies are designed, implemented and governed to promote systemic equity and population well-being, rather than individual clinical optimization. We will welcome Jess in a moment as she shares a drug for our formulary, her career anthem, and recommends a book for the Oral Apothecary Library. Our micro-discussion this week will be informed by the paper from the Journal of Medical Internet Research by Jennifer Cooper and colleagues from the University of Birmingham. Perspectives of healthcare professionals on the use of AI to support clinical decision-making in the management of multiple long-term conditions, an interview study. But first, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Welcome both.
Evening.
Evening. It's been a while.
Evening and afternoon. Yeah, it's been a while. What have you been up to, Jamie? You've had an exciting summer, haven't you?
What have I been up to? Well, there's one thing I've got to share, really. We've got a great series lined up, so we'll come back to that later. A few days after the previous series finished, after our guest Margaret McCartney, I got signed up to do a TED Talk. And so I did TEDx Swansea, From Prescription to Ocean, the Hidden Impact of Medicines. And I'm pleased to say that you two came down to support me. Your support was much welcomed and much needed. And yeah, I'm still waiting. My talk has been blocked, which is reassuring on one front.
Do you tell them why?
It's been blocked for further scrutiny. And so I think we knew this. When I mentioned what the topic was, and it involved medicines and healthcare and pharmaceuticals, rightly so, TED take a further and a closer look at that. And so I'm still waiting for it to be released. So I've had to supply, which again is reassuring, isn't it, in this day and age? I've had to supply the evidence base behind what I was talking about for those 15 minutes. What did you think when you came down, lads?
So, without blowing smoke, and I've seen you in a lot of settings, James. I've seen you on conferences. I've seen you do talks. And I don't think I've ever seen you nervous before. And you were.
I agree.
I mean, it didn't show in the talk, but in the run-up, and not just the day, in the weeks before, you really put the work in, and it showed. It was fantastic, and we'll leave the listeners to judge, but it was brilliant. So I think people are in for a real treat, and I think anyone who's interested in medicines will not only enjoy it, but I'm sure they'll be sharing it with their colleagues to show them what it's all about in terms of medicines optimization, medicines management, and stuff like that. So well done. I thought it was great.
I agree. You absolutely aced it. I think your stretch target should be 1 million listeners for that when it comes out.
Interestingly, I can guarantee 1 million listeners with £10,000.
Yes, I wondered if that might be the case. But I think I should go as far as to say that I hope it isn't me that gets it held up, because the one piece of data, I provided quite a lot of data for Jamie for the talk, and the one bit that he came back to me on was, listeners might remember when I worked out on the back of a fag packet, how many pills per second do we use in England? Do you remember what it was? 1,000 pills per second. And Jamie used it in his talk, and that's one of the things that to give him the workings out of my fag packet.
I hope it does come out. I hope it does make it through the editorial process. But if it doesn't, then we'll just use it on the Oral Apothecary.
Of course it will. No, you absolutely aced it.
And so the last time we met was at Clinical Pharmacy Congress, and Steve, you teased everyone at the end of the last series with a big reveal. So what was it?
Yes. So we were in London. What is the iconic design? If you think of London and iconic design, you think the London tube map, don't you? So Jamie, some time ago, came up with this stunning idea about a piece of art that would use the London tube map, but it would actually involve medicines, and each line would be, let's say a therapeutic area. So it's interesting, and I think relevant to tonight's topic, because we're going to talk a lot about AI. And Jamie, first of all, when he came up with the idea, and I said to him, it's a brilliant idea, James. And he said that he tried to ask AI to work it out. And basically it couldn't, could it, James?
It couldn't. I asked AI to smash together the London tube map and the British National Formulary. And it spluttered, coughed, steam came out of my machine, and computer said no in the end, really.
Yeah. So this is where I think tonight's debate will start, is that this is one up for humans versus AI, because I took it and worked out that I wanted to use each of the lines, if you like the northern line and the central line, and each line represented a BNF chapter or a therapeutic area, so cardiovascular, central nervous system, antibiotics, you name it. But each interchange meant that that drug was either used within that therapeutic area or indeed was causing a significant side effect within that. So I had to work backwards. So King's Cross has got the most number of interchanges, it's 5. And so what drug type do you think might meet that? In other words, multiple uses in chapters and causing lots of side effects? Boys, can you remember?
Prednisolone.
Prednisolone, exactly right. So that's basically how it worked out. And so we'd love to share it with everybody, but we don't want to get into a BBC cease and desist again. So we this time decided to ask Transport for London, and they allowed us to use it in the presentation, but currently we're not able to put it on the website. But if you want to contact us and ask to see a copy, we can do that.
Or you're a lawyer and you're going to offer some free advice.
They answered us nay.
It is a piece of art. Of course, we're biased, and my wife, who's also a pharmacist, worked out that actually, if you look close enough, you can actually see a medicine bottle within the tube, and lots of people who were there at the CPC have told me since that they now can't unsee seeing the medicine bottle on its side if you look at the circle line. So yeah, I think it is a piece of art. I know Gimmo thinks that the key to the symbols makes it more of an infographic, but I think overall we're pretty happy with it.
I thought it was great.
Very good. Okay, quick message then. Look, Series 8, we're moving to one podcast a month to be released on the last Friday of the month for our regular listeners and downloaders. Let's move on. Our great pleasure to welcome Dr. Jessica Morley to the Oral Apothecary. Jessica is a passionate advocate for health justice. Prior to joining Yale, she led policy research at the University of Oxford's Bennett Institute for Applied Data Science and served at the UK Department of Health and Social Care's as an AA subject matter expert. She's also a National Data Guardian panel member and an associate editor at BMJ Digital Health and AI. Welcome to the podcast, Jess.
Thanks so much for having me.
Welcome. In the green room, Jess, we were just talking about how busy you've been. What's on the top of your agenda at the moment?
I have been very busy because I was at home, as you've just said. I'm based in Yale, but I was at home in England for most of July and bouncing up and down different parts of the country, talking to mostly NHS analysts about things like the NHS 10-year plan and what the implications of that are and how you go about actually implementing some of the recommendations with regards to AI and also data. So that was my sort of practical traveling around, talking about that more bigger picture wise whilst I'm back in Yale, either teaching or I have some ongoing research about how you use AI for population health. Those are the top things at the top of my agenda at the moment.
So welcome, Jess. You're very welcome on this podcast. Just for the listener to know that if you might have heard her voice, she's been all over the place. She's been on lots of podcasts, has been on the radio. She actually featured on the BBC Radio 4 podcast, which is called The Briefing Room, which is a phenomenal programme. And Jess was one of the experts on that. And that's when I certainly first heard and thought, wow, got to get this lady on. She seems to talk a lot of sense around AI and in particular. So, yeah, so pleased to have you on. We want to talk about AI. And our last episode was about the wild west of skinny jabs. And I feel like we're now moving to perhaps tonight to talk about the wild west of AI in healthcare. So I feel like we've got an appropriate expert with us. And hopefully I won't look like too much of a laggard by the time we get to the end of the episode.
Is it fair, Jess, to describe it as the Wild West?
Oh, absolutely, 100%.
Good, we're clear on that. So you mentioned about the 10-year plan, and so perhaps if we could just, for the listeners, and you could perhaps tell us, you wrote, again, a wonderful piece on LinkedIn, I think, about the 10-year plan. So do you want to tell people what you think about the 10-year plan from where you are, and then perhaps just explain to people that you're coming at things from an IT and a medical, almost as an ethics person as well, aren't you? Perhaps you could just explain that for the listener, to the principles of ethics, if you like, medical ethics.
Yeah, absolutely. So I am, as we were talking a bit before, I'm sort of fairly hard to categorize in terms of what discipline do I fall into, but broadly it would be social science, and then what I largely do is digital ethics. And in terms of how we think about that and apply that to the concept of AI in medicine, so if you think about the bioethics principles, which most people are broadly familiar with, so you've got beneficence, non-maleficence, autonomy, and justice. And sort of very high level thinking, that is, beneficence, do something good, so do well. Non-maleficence is the avoidance of harm. Autonomy is the protection of the patient and indeed the clinician's sort of understanding of their own self and their ability to make decision making. So if you think about things like informed consent, that is generally the protection of the principle of autonomy. And then you have justice, which is about equity and fairness. And then in the world of digital, and especially in the world of AI, they often apply the concept explainability as a sort of extra principle on the end. You can debate whether or not that's a new one, but it's really just about making sure that we can understand the way in which these types of technologies and systems or software are working. And that is because it is a bit like a meta principle. It also protects beneficence, non-maleficence, autonomy, and justice if we can understand what's going on. So that's sort of what I try and do. And then I try and think about, okay, if we are implementing this type of technology, what are the implications of that? Both for individuals, but also at a system level. Is this really the direction of travel in which we're going in? And so I guess with regards to the 10-year plan, the 10-year plan was much awaited, and then it arrived without an operations chapter. So whether you can generally call it a plan as opposed to a vision, I think is somewhat debatable.
I agree.
But what was, I suppose, interesting for me was it says AI more than it says anything else. And which I guess flags up for me, my biggest concern, which is largely that I think the healthcare system is putting too many eggs in one basket. As much as AI is a very big basket, we probably don't want to put all of our eggs in there.
Do you think it's because they used AI to write the report?
Very possibly, but I don't want to do a disservice to the people who I'm sure worked very hard on it. But yes, there are some things that would suggest AI was involved. Some tricks of the trade, if you ever want to look for whether or not AI is involved in writing. AI has quite a strong, what we call data print. It has a quite strong voice, and there are words that are fairly indicative of its use. Delve is one, but another one is fundamental and fundamentally. So if you start seeing fundamental come up a lot of times in any form of text, there's a pretty strong chance that it's been written by
this
AI.
is the kind of stuff that we need to hear. So sorry, I interrupted. Yes, tell us what you think about the 10-year plan.
No worries at all. So I think, I think there were too many things. And then what I was saying in my LinkedIn post was there are some things that I think are good. I think it's really great that we see at least a piece of policy coming out that's being relatively honest about the state of the healthcare system and that we need to change. There was some, although I think it didn't go far enough, there were some nods towards this idea that actually we probably do also need to invest in the system. So you see things in there that talk about healthy starts being reinvested in, thinking about the sort of population health element. But then it goes really, really strongly into this message about digital being a solution, especially being the solution to shifting care out of hospital and back into the community. And AI plays a really strong role in that. And then what I do in the LinkedIn post is basically break it down into things that I think are myths. So where I think things are being based on slightly false ideas about the capabilities of AI and also about the quality of the NHS's data. And then the other things I sort of talk about is things that are more worrying. So there is a fairly prevalent concept in the 10-year plan that they want to use the NHS AI, the NHS app as like this sort of single front door, which is the NHS's lovely favourite phrase, is that we want to have one front door, and now that front door is the NHS app. And in that, they want to have things like My NHS GP, which is a chatbot that would allow people to sort of interact with. Those are the ideas that I think are worrying. The things that I think are mythical why I think that those ideas are worrying. So,
yeah, I thought it was a great piece, and a couple of things that stood out that there was contradictions in it, wasn't there? There was on the one hand talking about let's go back to the 1950s and have a family doctor who's with you for life, but then on the other hand, you're doing everything through an app in your pocket, and that didn't make sense. But then, having read a bit around this topic in preparation for this episode, I think the stuff you're doing about ethics is the most important thing in AI at the moment, because no one's talking about it. Everyone's talking about technically what AI can do and not thinking enough about, not the risks, because I think people get that, but the bad things that it creates doing it. And I've not heard that term before. You use the term explainability, and I think that's really good, because you have no way of knowing how AI has reached the decision it reaches, so you've got no way of checking whether it's correct. I'm a big fan of AI. I use it. I've always sort of been a fairly early adopter of tech, and I think it's great. But I think it's really dangerous to start talking it up in the way that the NHS plan is talking it up, because I don't think that the information in the NHS exists to teach AI to do the things that it's saying that it can do.
Yeah, that's exactly it, and that's one of the contradictions that I flagged. There is definitely this one where it's like you say, we want to go back to the roots, and then at the same time sort of completely dismantle that concept. So that seems a bit at odds to me. But the other one that I think is a really significant contradiction is they say very strongly we want to use AI and digital to limit or reduce inequities, and then that is almost impossible with the types of AIs that we currently have, especially because we just don't have high quality enough data on everybody. We have good quality data on some people, fairly average quality data on most people, and then quite poor quality data on a lot of people. And those are the people who tend to need healthcare the most. And if you start creating this system, you sort of split it in half between the data haves and the data have-nots.
I think that, like you, I've not really commented on what I think about the 10-year plan, so I'll dive right in now. But really, like you, I'm actually not going to say anything until I see the delivery plan, which apparently is not coming until September. Because if you remember about how they asked the public and loads of organisations, look, I put in the oral apothecary, remember our 75 years remedy that our patients came up from Series 6. So it's a distillation of all of that kind of stuff. But until the delivery plan comes up, for me, it's just a bunch of words on a page, really. Mm-hmm. And it also feels like two different. I joke about the AI, but I'm sure there's some of it. But it feels like there's two people writing it. It feels like there's a tech bro, and there's somebody trying to talk about neighborhood health.
Yeah.
And the tech bro won. Because if you look at, and genomics comes up, every time medicines are mentioned, genomics is mentioned, right? So it's the same stuff about, the magic, the alchemy. We could have been called the oral alchemists, but, that idea of just, it's magic, we can turn it into gold, everything, whether it's about AI or whether it's about genomics. And it's so far off the vast majority of what we do, like the 80-20 rule, for example. So for me, it feels like it's two people writing it, and the tech bro won. And, if you want to talk about patients and neighborhood health, what would you put on the front cover of your 10-year plan? You certainly wouldn't put a DNA double helix, that's for sure.
You put a car, wouldn't you?
You would put a car, absolutely. And the other thing, we should just say this, there's one thing in it, which again, I'm lots of people talking about it. I think they misspelt it. They called it the SNF. Of course, what they meant was the BNF, so the single national formulary. And yeah, lots of exciting stuff about what it might look like. Will it ever be achievable? And I'd consider myself to be a skeptical, curious, positive person, if that's not too much of a phrase. And I'd love to see it come off. I just at the minute, till the implementation comes out, I just don't get it. But one thing I have said, and I do strongly believe this, and I put this out there, is if we do get such a document, every single drug needs to have a section in it that says what are the rules, what's the guidance about review and deprescribing, because that's the area in which I'm most interested in. So that's what I'm going to say anyway about the 10-year plan. Jane, what do you think?
I've got no thoughts on the 10-year plan, but I would like to come back to Jess's briefing episode with the BBC where you described the implementation gap, Jess, yeah. Mm-hmm. And I thought that was great. So can you just, the three of us have listened to the briefing room a couple of times in the last couple of weeks, really, but for our listener, can you just remind us of what you mean when you talk about the implementation gap, in particular around AI?
Yeah, absolutely. So essentially, there is a huge amount of investment into the development of the tech. So there is no shortage of algorithms going on. There are many people making clever things inside universities, inside private companies. There's huge numbers happening. Less than 2% of those models actually make it from the sort of lab or into the actual clinic. most of them die somewhere in the translation between the lab and the clinic, and then a lot of them also fail once they are actually implemented, and you see a massive drop off in the performance. So even if they were doing really, really well when they were tested, once they hit the real world, they sort of hit the skids and everything falls out the window, to mix my metaphors in a great way there. So the reason that happens is for multiple reasons, but if we break it down, it's mostly about infrastructure. And the metaphor I've used most often in the context of the NHS is it's like trying to run HS2 on rotting wooden railway tracks. We have technical infrastructure in the NHS that was never designed to be able to run and support computationally expensive high performance algorithms, which require access to very large volumes of highly sort of granular data in real time. So if you want to run these things, they need to be able to have access to the electronic health record. They need to integrate. They need to be able to pull the data in real time. You need to make sure that clinicians are trained in being able to provide that information at the right point in the workflow in order to get the information out of the algorithm. You have to make sure that it's interpretable at that point in care. All of that requires things like robust data exchange and making sure that data can talk to each other. So that's solving the problem of interoperability, which has been an issue for the NHS for basically the entire time I've been alive. And it sort of multiplies from there, because we then also have legal issues. So we also have legal infrastructure, which is things like protection of liability and negligence, and who is responsible if an algorithm makes a wrong decision. And then who do we tick off? We don't know, because it could be anybody in that pipeline, from the person who created and curated the data to the person who trained the algorithm to the person who's interacting with it. We don't have sort of appropriate discrimination law if these things are definitely causing issues to do with bias. So they're working very well for people who, look like Jess, white middle class Caucasian cisgendered women. They don't work well for other people who fall outside of that norm. So that whole infrastructure is sort of broken. And we've gone a little bit cart before the horse with AI implementation, where all of the tech is ready to go. People are trying to sell it. The NHS doesn't actually necessarily want to buy it, because it's not necessarily solving a problem that it wants solved. It's a solution looking for a problem. And then we don't have the underlying infrastructure in order to make it work in reality on top of that.
Yeah, and you're spot on. And I think I work in quality improvement, and that's all about how do we take evidence and put it into practice. And actually the biggest barriers that we face are the complexity of the NHS and the culture. And that's not to say there's a bad culture or a resistant culture. It's just that you've got to consider the culture and how people behave. And that's what we haven't tested en masse yet with AI. There's all sorts of unforeseen consequences for how this works. And also, they're looking at parts of the system instead of the system. And so I think, there's a maximum QI around. There's three modes of improvement. There's doing things well, doing things better, and doing better things. And I think a lot of the AI stuff is really just about efficiencies at the moment, rather than thinking, actually, there's a paradigm shift here. We could really change how we practice here. And that's going to take time. So I'm not being negative about AI. I just think that it's a 20, 30 year project. It's not going to happen. So I've heard things like, in 5 years' time, we'll have fully licensed AIs who registered as doctors and stuff like this. And it's just, as someone who's been involved in, I know it's different, but once it hits the culture and the real world, I think we're going to spend a lot of time on unraveling those unforeseen consequences.
You mentioned putting the cart before the horse, but the other thing I wrote down was around, you talk about, we might come on to talk about ambient AI and the ability to listen to a consultation and turn it into something. And we now all of a sudden everybody's gone, oh, maybe we need to think about the governance. And so Wales apparently has just published something this week. I know I saw that you'd written, Jess, that had happened in England very recently, and some of the stuff that I've listened to. And so it's almost like, again, it's like shutting the door after the horse has bolted, because everybody's saying, oh, we're already using it. And so a bit like us talking about the skinny jabs, right? Who didn't think that that's what was going to happen if you just allowed people to get private prescriptions? Today in the news, guess what? If you're not a health professional, you're not going to be allowed to do butt cheek operations anymore. What's it called? Butt lift. Well, any sensible person would have known that wasn't a good idea in the first place. And the last thing I'd say on this is that the more I thought about this, the more I thought about and the magic beans and the alchemy, this is like a new drug. This is like those of us that are used to pharma coming round and trying to sell us a drug, particularly in the 1990s, right? How heavy-handed all of that was and how it'll change the world. I'll give you rosiglitazone, I'll give you rofecoxib. These were all on the 9 o'clock news about how they were going to change the world. Guess what happened to both of those? So that's how I feel about it. And I said I don't want to come across as a Luddite because I know that AI can help us to be more human in the human job that I do as a health professional, but I have great concerns about it for those very reasons. And it's a bit like an over-marketed new shiny drug.
Yeah, absolutely. I mean, you mentioned before that I used to work for the Bennett Institute, and you're going to have Brian McKenna on this series. So obviously that whole thing is run by Ben Goldacre. I always think that there's a real massive parallel. Obviously, he wrote Bad Pharma. We really are talking about bad algorithms, and it's because that entire pipeline is not there. Like, one of the research projects that we're working on is looking at clinical trials that are trying to test AI, whether or not it actually works in the intervention, and the science isn't there. There isn't good trials of it. The trials reporting is really bad. And then you have exactly like you say, the tech bros who go in and sell exactly in the same way that in the past you might have had pharmaceutical reps trying to sell to you. And whilst we went on that sort of pathway of improving things with pharmaceuticals, we really haven't taken that learning with us into how do we build this from the beginning with the world of algorithms. We just sort of went, oh, this is a shiny thing. And sometimes I joke about it being a bit like that, the nursery rhyme, sticks and stones may break my bones, but words will never harm me. I think sometimes there's this sort of myth that because it's never touching a physical person, it's not going to cause harm. But that's just fundamentally not true. I said the AI word. I'm not an AI. I am a human.
So just taking that one step further on the pharma comparison, conflicts of interest in this world as well?
Huge conflicts of interest.
Why are we not surprised?
For the tape, Jess threw her hands up, everybody.
She's definitely a human, this one.
Yeah, I talk far too much with my hands, which doesn't work when you're relying only on my voice. But yes, all of the problems that you will have seen with pharmaceuticals, so conflict of interest, publication bias, suppression of evidence, all of those types of things are coming up again and again and again and again in this sphere. And they're potentially magnified because you also have an entirely new party entrant into the system. So this is not just researchers or even pharmaceutical companies, because pharma companies are playing in the AI space quite significantly, who at least have the semblance of an idea that they're supposed to be doing all of this stuff. We also have now Silicon Valley, who don't know health. They have never really touched it before. They just know that health has a lot of data, and they're now entering into this traditionally highly regulated space and don't know that they're supposed to have followed all these rules, and then the rules themselves are kind of broken and not really adaptable to this new world. So you have this layering effect of the risk, hence we ended up in the Wild West.
Okay, well, I think this is a good point to move us on to the next section. And just like with new drugs, show me the evidence, and if you've shown me that you've done a good job and it looks like it's going to be great, I'm prepared to use it.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
So, Jess, one of the pleasures of coming on the Oral Apothecary as a guest is you get to give us 3 things, okay? We do them in a strict order because we're pharmacists. So the first one is a desert island drug. So this is a medication or a drug that has a very powerful memory for you. So what would you like to offer?
So I'm going to give you a drug combination, which is sertraline and propranolol. So the reason I give you those 2 things, so I have always been a fairly anxious person. There are multiple reasons as to why that is happening, but it just always happened. And then there have been several times where that has become a bit unmanageable, but the most recent one was when I was trying to do my PhD, trying to also work full-time for the Bennett. We were trying to write the Goldacre Review. We were trying to run Open Safely. And something inside me, whatever it was, just sort of went, this is too much. I can't do this anymore. Please stop. And those 2 drugs sertraline and propranolol probably helped get me back on track so that I can continue to do what I do. I genuinely don't think, had I not had them, plus other interventions, I would have been able to finish my PhD and then end up back in Yale.
Wow. Well, thank you. I mean, thank you for sharing that. You know, you can give us anything. So that's a very personal story, but thank you for that. And let me just tell you that you're not alone. I've taken both of those drugs for the same reason. So, you know, it's quite a common issue. So, yeah, thank you for that. I don't think we've had fluoxetine before. I don't think
we've had a beta blocker, haven't we?
I think we have had a beta blocker, but I don't think we have propranolol. But I think propranolol is a drug for the ages. And you know the guy, what was his name? Was it Professor Black? He also invented cimetidine, which was the very first H2 antagonist. I mean, what a way to go. Okay, your name is attached to cimetidine and propranolol. That's fairly impressive.
I've got an article to go on FLAC to do propranolol because it's a really interesting story. But also, we've got hopefully Dr. Lawrence Gray coming up later on in the series. He's a toxicologist, and propranolol. You probably won't want to listen to that one, Jess, because it's about the toxicity of propranolol. But you're fine with the way you're using it. Yeah, that's it. Yeah.
Listen to James McCormack. Low dose, you'll be fine.
Yeah. It's so it's a really interesting drug, but it's great to have that personal story as well, and I'm sure lots listening. Well, as Steve has said, lots listening will empathise with that.
You're too young, Jess, but back in the day when, again, snooker was big in the 1980s, all the snooker players used to take propranolol to keep them calm, you know, when they were at the table to try and get the big break. So and it's used still to this day. You know, people doing OSCEs and exams and driving tests and that kind of stuff. I think it's a wonderful drug, propranolol.
All the snooker players?
Well, a lot of them. Jess, the second thing that we would ask guests for is a career anthem, which we have a Spotify playlist, an oral apothecary playlist. So what would you like to offer us for that?
So for that, my this was a bit like Sophie's Choice, but I will give you that it was Long Live by Taylor Swift. So I love that song. I could
knew
listen
you were a
to
Swiftie.
it on repeat. I know, that's why it's like Sophie's Choice. It's like 234 songs, but Long Live is definitely the one.
She's a talent. You've got to give it to her.
Yeah, I love that song. I could listen to it on repeat, but I also like the messages. So many of her songs are about love and etc. Whereas that one is fundamentally about your friendship and the people that you bring along with you. And I just love the line, "Long live all the magic we made." And also the one about I had the time of my life fighting dragons with you. Talking about all of this stuff of the Wild West, and working in this field often feels like you're constantly fighting dragons, and you can only do that if you have good people who are by your side.
Excellent. Yes, I've seen you write a lot, and people have said, "Oh, Jess, you've managed to get another Taylor Swift song into your."
She came to Cardiff, and the place went crazy. It really did.
There's a article on Taylor Swift in Harvard Business Review from a couple of months ago, just on what an incredible businesswoman she is as well, you know, and the whole thing around her of how successful she's been. It's a great read.
Okay, bonus question: who previously picked a Taylor Swift song? This is not for Jess, obviously. This is for the listener, and more particularly Jamie.
I got no idea. I thought it was the first one.
Bapu Jenner.
Oh, yeah.
And do you remember why he picked it?
I do remember why, because he was struggling.
The story, there you go. The story is what counts. Go on then.
Well, he was struggling for a choice, but then he mentioned that he was driving his daughter somewhere, was it, or something like that? Yeah.
Yeah, and that's what was always playing on his iPod Shuffle. Yeah. There you go. So Taylor Swift enters, not for the first time, into the Oral Apothecary Spotify playlist. And yes, it really is on Spotify. Okay, the third thing, Jess, is something for the Oral Apothecary Library. So I'm looking forward to something really clever from you on this. What would you like to offer the listener?
So this was really hard, because I was originally going to try and recommend The Philosophy of Information, which is written by the Luciano Floridi, who I work for over here. But that, I think, if I was to say that, would probably involve a mutiny, because it is extremely difficult and not particularly related to health. So the one that I am going to recommend instead is Health, Justice, and Argument for the Capabilities Approach, which is written by Sridhar Venkataparam, and it was published in 2011. And the reason I think that's first of all, I love the book. I think it's incredibly well written. It's very engaging. It touches on multiple topics, but I think it's a really interesting one and a really good parallel for the type of thing that we're talking about, because it's essentially saying that not everybody has the same capability to become healthy because of the environment within which they live, whether that be the restrictions of their job, whether it be the restrictions of their environment, whether it be the restrictions of their body. And you can't sort of police people to hit these targets that are not related to themselves as an individual. And I think in an algorithmic space, we increasingly forget that people are whole people that live in the real world, that have real constraints on what they are able to achieve. And rather than sort of trying to turn them into these optimizable machines where we can say, if you just do this, if you just tweak this based on this algorithm's advice, we should be really thinking about what does it actually require in order to give people the capabilities and the capacity to maintain their health in a way that is meaningful to them. So that's why I'm recommending that book.
I mean, that's actually good, and that echoes my point about complexity. That's why a lot of these tech things fail, because people don't appreciate the complexities of the fact that everyone's different, isn't it? And actually, that book sounds like it's got echoes of Michael Marmot in it as well, which is
it does,
a book that's come up a few times, I think.
Yeah, and also we might go on to talk about this, but Jess, you might not know, but we did a whole episode about the inverse care law, which is obviously some of which of what you're talking about. And I suppose, having worked as a generalist all my life, sometimes I give grief to specialists because I feel that sometimes they are further removed from what I would call the real world, and they live more in the ideal world. So I think I'm definitely going to read that, because that sounds right up my strauser.
I wonder if we can already predict, can we, that there'll be an inverse AI law, in that the people will benefit from it are the people who least need it. It'll be the poorest and most in need of AI that won't benefit from it.
Yeah, so I refer to it as the inverse data quality law. So the availability of high quality health and care data varies inversely with need, and then that means that AI is entirely reliant on the data, and so you do therefore get this inverse law. Absolutely.
Okay, excellent. So health, justice, and argument from the capabilities approach by Sridhar Venkatapuram. We'll put that in the show notes. Okay, great.
Also for the show notes, Jess, we'll put a link to your recent BMJ editorial, which covers a lot of what we've just been talking about, and some of your thoughts as well. Can a digital NHS be equitable? So we'll put that for our listeners as well. All available on the website.
theoralapothecary.com.
Our micro discussion next. What do we have? From the Journal of Medical Internet Research, perspectives of healthcare professionals on the use of AI to support clinical decision-making in the management of multiple long-term conditions. So on message for the podcast, multiple long-term conditions, we spend a lot of time reflecting on those and talking about those. An interview study by Jennifer Cooper and colleagues from University of Birmingham. They interviewed 20 healthcare professionals, some GPs, geriatricians, nurses and pharmacists. They used a case study approach. Interestingly, they used a different case study for the GPs and geriatricians and a different one for the nurses and the pharmacists. We can discuss that. What did you think about it? And I'll just declare that we covered this paper in Cardiff Metropolitan University Journal Club last week. So you remember prawn cocktails, steak and Black Forest Gatto? Well, journal clubs are right up there with that list. But they're all going strong.
All from the 1970s.
They're all going strong and all deserve their place in a modern world. So yes, what did you think of the paper?
So I thought it was a fairly interesting paper. I was not surprised by the findings. So the findings were broadly that people think that AI will make things more accurate, but are worried about the implications for understanding patients from a holistic perspective, which is obviously extremely important in all patient care, but especially in multiple long-term conditions. I don't know why I'm telling you that. You obviously know that. But I was not surprised that there was this bias in the thinking from the respondents that AI will automatically make things more accurate. The other one that I think was the other point that I thought was interesting and probably worth discussing, especially given our conversation earlier about the long-term plan, was this sort of hyperbole that they think it will save time eventually. There was a lovely line and a lovely quote from someone that said it will save time eventually. And I think that point about the eventually doesn't get mentioned enough. So I really liked that specific quote.
I listened to a podcast the other day where they've done some research in the States on ambient scribe, and that's what they found, isn't it? That actually it hasn't saved any time. You could argue that it's improved the quality of the notes, and the GPs or the family practitioners, whatever, were sort of happier. But in terms of time saved, it didn't save any time at all, and that's what it's being marketed on.
Exactly.
I liked it. I think the figure about the summary of the concepts that describe health professionals' attitudes, they used it's based on a concept set by somebody called Buck, I believe. But if you like to look at diagrammatics of what's involved here, you've got individual characteristics, you've got environmental influences, you've got concerns, i.e. the affective, and you've got expectations, the cognitive. And so, yeah, I there's a lot in there, isn't there, in relation to, as you say, we're very interested in this kind of part of it, because I'm going to guess that where I said earlier about I want AI to do some heavy lifting for me as a clinician, so that I can be more human in my approach. And I think that's what they were trying to get out of the health professionals in this study, weren't they? And perhaps I'm sure that we'll be coming back to this subject, because you might remember when we had Professor Lauren Walker on, who's a clinical pharmacologist, and she's actually taking part. She's the lead researcher actually on something called DIAN-AIR-X, which is looking at trying to do this for people who do structured medication reviews. So people with lots of morbidity and lots of medicines, trying to, if you like, scrape through what's in the notes and describe something that, if you like, the way I understand it, is it would end up with being what we would think of as like a smiley faces kind of chart, to try and help the benefits, risks, alternatives, and nothings. In other words, to try to help the conversation, but to save the clinician some time. But ultimately, as we always come back to in all of this, isn't it, is that we are the human, we are the ones that need to use the AI, but we need to make the decision with the patient and us, the professional. And so that comes across very strongly in relation to all of that, doesn't it? The one thing that does, again, irk me a little bit when people say about, oh, well, the AI will be able to, identify all these interactions and it will make it safer. Well, I'm sorry to say, but we've had interaction checkers on computers for decades, and let me tell you, public, they just get ignored. So why do we think that if we call them AI enabled, that there any more reason that people will actually take any notice of them?
And they get ignored because there's a human in the middle that doesn't play by the rules that the algorithm's working to, doesn't it? I mean, I thought there was something in there, Jess, about what you just talked about earlier was, the general trend in there was about AI improving safety and efficiency in decision making, helping clinicians synthesize multiple things to help them make a decision. But then one of the quotes was from the GPs was exactly what you were talking about earlier, was the AI must explain its choice, especially when we're making trade-offs in long term.
Yeah, exactly. There is this real, I think, and that's why I said that I'm not surprised that this bias in the thinking came up, that it's going to make things safer, going to make things more accurate, all of that type of thing. Because I think we are so used to, and it is literally called automation bias, we are so used to thinking that computers are better at things than us, that there is this assumption that it's going to be able to do those kind of calculations much better. But we have absolutely no idea whether it is making those decisions based on signal or noise. And that could be completely irrelevant, and it could be just the whole correlation is not causation type issue. And we really don't want to hand over that level of decision autonomy to something that we can't query, especially in something as complex as this type of environment.
Very good. Well, let me share with you what discussion came up after an hour and a half of Journal Club.
An hour and a half?
Was that after the Black Forest
After
Gatto?
the Gatto. An hour and a half of over lunch and mapping it against the University of Oxford sort of qualitative framework. It came up a bit short on its methodological rigour, but nevertheless, obviously those quotes are fascinating and interesting, and that's why I brought it for discussion today. But there's a few things in there that, on a deeper dive, that you tease out, that there's a few people that were interviewed definitely have a strong interest in AI and were on, I'm not sure whether they had just an interest in developing, and actually the piece of the program that it comes from, and they do mention this, to be fair, but it comes out that the study, which aims to develop an AI decision support tool so they could have felt compelled to discuss AI more positively than how they actually felt. So again, there was 2 or 3 stakeholders in there that probably very positive about AI. But yeah, it came up a little bit short. But again, that doesn't. I think it's Jennifer Cooper's PhD. I think that's what the research is. But those discussions with the healthcare professionals were a good starting point for discussion. There's a little bit of, I don't know, it's like patronising tone, I think, that they changed the case studies for the non-medical prescribers. And I think one of the responses was from one of the older geriatricians that AI might be more of a risk with different prescribers, or perhaps even younger prescribers coming through the system, that it was a useful tool for more experienced prescribers, but actually in the wrong hands could be a problem.
I think that's true, though. I would accept that. And so when you're learning and you're a sponge, and when I get trainees and they say, "Oh, how do you know all this stuff?" I was like, "Well, I've been doing it for 30 years, okay, and there's pattern recognition in the same way they pattern recognition from AI, I guess. So, but when you're learning, you want things to help you. But I think the point, and we've not really discussed this so far, but when they talk about hallucinations, don't they, and the fact that the AI can get it wrong, it's a bit like, the analogy for me is the calculator. If you spent your whole life only using a calculator and you've put the wrong number in, you can't work out the simple maths of that can't possibly be right. In the same way that Google Maps, you hear these stupid stories where somebody ended up in the wrong country because they followed the postcode. So that's my worry about these, is that, yes, it can be helpful, and it should be, but ultimately, we still, as I said, I keep saying this, it needs to make us more human. And as a health professional, that needs to mean that we need to get better at listening, asking questions, discussing the risks and benefits. And the final thing I'll say is that one of the people that probably influenced my career more than anybody else was a consultant endocrinologist called Ali Khalili, who'd come over from Iraq. He worked in Halton Hospital in Liverpool, and I spent a lot of my training with him. And he used to say about stuff, and he said, "Look, we need to make things simpler, not simple. Because if we make it simple, people stop thinking."
Very good. A big thank you to Jessica for joining us on The Oral Apothecary and for sharing her stories, her desert island drug, her career anthem, and her book for the Oral Apothecary Library. Coming up next time, Gimmo's mentioned him already, we'll be joined by Dr. Lawrence Gray. Lawrence is a consultant clinical pharmacologist at the Welsh National Poisons Unit. Join us next time on The Oral Apothecary. You can contact us via X at Oral Apothecary, just about. You can follow us on LinkedIn. Please do sign up to our LinkedIn page. Gimmo, what do you want to say about that?
Yeah, no, just like we're going to put a little bit more stuff on there, because we're obviously 3 middle-aged men, we're all experts on social media. We're going to, after failing on Instagram, we're going to give LinkedIn a go. Can't be bothered with, now, I'm doing a bit on Blue Sky, but Twitter's obviously a car crash at the moment. But yeah, we're on LinkedIn, and we put a post on there about people's music choices. So big thanks to Chris Bolton, Jonathan Underhill, Sarah Tinsley, Tom Tatchell, Dr. Helen Hall, Simon Cooper, and others, Anne Mason, Deborah, who all sort of chipped in with their choices. A particular mention of Anne Mason, because not only did she pick a great song, which was Living on a Prayer by Bon Jovi, she talked about how it raised memories of pre-packing 10,000 Pen V tablets into 28s in bottles, and so that gave a big memory for me, because do you remember pre-packing antibiotics?
You didn't want to drop 1,000 pot of ferrous sulfate tablets on the dispensary floor.
Yeah. So one for the, probably pharmacists over 40 will know what we're talking about there. So that's great. So thanks. And then I guess on to this week's final ingredient. And so So thank you, Jess. I really enjoyed that, and I've really enjoyed reading your stuff as well. And there's lots to think about, and hopefully we'll put some links in the show notes. And as we said when we were all reading this, thought we could do 10 series on this. There's so much in it, but I think what you're doing is really important around getting people to think about the ethics. So thank you for that. But in the spirit of today's episode, for the final ingredient, I asked ChatGPT to write it. So I prompted it. I explained what the final ingredient was. I linked it to the website and said, can you write me a quirky end of episode story based on the theme of AI medicine? So here's what it come up with. The paracetamol that can think. So in 2022, a group of researchers at a biotech company did something bold and a bit terrifying. They'd been using artificial intelligence to design new drug molecules, and the goal was to find novel antibiotics and other helpful compounds, and it worked. Their AI could search the chemical space faster than any human, predicting which structures might actually work in the body. But then they asked themselves, what if we flipped the objective? So instead of telling the AI to search for helpful drugs, they told it to look for harmful ones, specifically molecules that could be used as chemical weapons. They didn't change the algorithm, they didn't hack the system, they just changed the prompt from save people to harm people. In under 6 hours, the AI generated 40,000 potentially lethal compounds, including variations of VX nerve agents and others the scientists didn't even recognise, all by just tweaking the prompt. They never actually synthesized the molecules, but the message was loud and clear. We've built a system that can create both penicillin and poison, and it doesn't know the difference. So there you have it. In the world of medicines, AI isn't just a tool, it's a reminder that the ethics, the intention, and the human hand on the switch still matter. So thank you for that, ChatGPT. It wasn't bad, actually. I don't know if it's true. I did ask it for a reference and it sent me somewhere. So explainability wasn't great, but actually you drew the same conclusions that we have today about humans. So well done.
You have been listening to a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker and Jacob Howard.
Thanks for listening to The Oral Apothecary. As ever, we dispensed with accuracy.
This episode of The Oral Apothecary is sponsored by jamiehayes.co.uk.